All right. Thank you, Nikolai, for the nice introduction. So first of all, I would like to thank you, the Evosep team, for providing me the opportunity to, let's see here, just have to put down this one, like that. So first of all, I'd like to thank the Evosep team for providing me the opportunity to present our work and views at the webinar today. So I'm in a combined position with routine responsibility of validation and monitoring of plus 50 clinical protein and hormone assays in endocrinology, oncology, and prenatal screening. And we use, as other labs, fully tracked automated immunoassays and also standalone LCMS for my subset of clinical tests. And so my main research interests is targeted proteomics and biomarkers of endocrine disorders and pregnancy. So Odense University Hospital serves the area of the central island Fyn and the southern region of Denmark. And our department produces, just like Nikolai at Rigshospital's department, around 10 million lab tests every year for our hospital departments and private practitioners. And I also here highlighted some of the departments with our nearest local research collaborators. So actually our hospital is going to move in less than 2 years, and will then become merged to our university campus in the outskirts of Odense, with patients entering in the southern part of this complex, and the SDU students from the northern entrance. There will be 3 kilometers under the same roof. And so there's a strong anticipation that this will actually facilitate additional multidisciplinary innovation projects and synergies in many areas. So the outline of my talk, I will give a short overview of the methodology and technology used in targeted proteomics and present a few examples of promising clinical applications of this technology, as well as examples from our own work in biomarker research. So first of all, also as Nikolai mentioned in his talk, I would like to emphasize that in the heart of clinical biochemistry, we care for assay performance and relevant assay interval that covers the reference intervals of normal healthy population. And this is what our clinicians use to guide treatment and patient care. And we also, by that, need to quantitate with precision and accuracy as controlled by internal QC and external QC. And optimal calibration is actually essential in laboratory medicine and clinical diagnostics. So when we look at targeted mass spectrometry, we routinely measure hormones, drugs, and other compounds in blood using robust high-transmission triple quadrupole mass spectrometers. And when we look at the workflow, there are quite similarities and differences evident with respect to small molecule and proteins, with some variations in sample prep, LC conditions, ionization, and so on. So if we look at the targeted proteomics workflow, it mostly differs from small molecule quantitation in that we generate peptide targets by enzymatic digestion to obtain unique proteotypic peptides. And depending on application, protein or peptide enrichment can be performed prior to SRM-MS to gain further assay sensitivity. And targeted analysis has for decades depended on robust triple quadrupole mass spectrometers known for their high transmission and selectivity, albeit at a low resolution. But in the last decade, the development of orbit trap mass spectrometers enabled a widespread use of parallel reaction monitoring for targeted analysis. Okay, so MRM protein assays can be developed for virtually all species, and we just need the sequence information from genomics or proteomic studies, and can do virtually all types of fresh tissues, cells, fluids, using very low sample amount, and the time use at the same time use multiplexing without any cross interference. Also, assays are often scalable to large biobanks. So we have used MRM assays in different studies, ranging from studies in bacterial antibiotic resistance to isoform specificity in cardiovascular disease, in mice models of atherosclerosis and aortic aneurysms, and further to studies in formalin fixed paraffin-embedded human arteries, where we also target hydroxylated modified peptides, and also we of course have been done biobank studies for multi-marker prediction, especially in pregnancy-related studies. And so a former postdoc in my lab, Tina Ravnsborg, performed a targeted MS-based search for predictive markers of gestational diabetes, and she assayed roughly 30 proteins in a cohort of 400 samples and evaluated regression models from a training set, and then in a 25% validation set. And I won't have time to walk you through the ROC curves, the ROC analysis, as Nikolai pointed out how they are interpreted in his talk. But my point in this study is that she developed a highly reproducible assay that was somehow quite time consuming. But if we look on the right side, we can see that the CVs of many of the proteins were quite comparable to immunoassays that we also used for some of the protein targets. And because at that time we ran longer gradients, the assay was quite sensitive to shifts in retention time, which caused a number of sample reruns due to out of the timed windows failures. So by improvement of sample prep and robust LC, we have now developed a more solid platform to perform biobanks, or to support biobanks with samples in the thousands. And in the upper right corner, we can see it's some measurements, MRM assay measurements from a cohort of 1,000 plus maternal serum samples of first and second trimester, where we assayed plus 20 proteins, and this is ApoB, the set score distribution across batches that we use for the normalization. And so this is just for kind of the initial part. So I would like to now shift to clinical applications. So there are already clinical applications in our labs, and also some cases moving towards it. And here's some examples from different medical areas that has been promoted during the years. Firstly, oncology and thyroglobulin testing in thyroid cancer follow-up, and also M-component testing in multiple myeloma, as Nikolai talked about, for hematological cancers. And also to mention amyloidosis typing, which is actually not a cancer, but it's a condition associated to cancers. And in endocrinology, assays have been promoted for insulin-like growth factors, and glycated albumin. And in rheumatology, MRM-based biological drug monitoring has been promoted, although the development of autoimmunity against these biologics seems to be the real clinical problem. So we are actually currently working on those targets marked in green, and we do that together with Bharat Kumar Raguraman, who's industrial postdoc and project scientist shared between Evosep and my group at the hospital. And we are developing a method for glycated albumin in serum, plasma, urine, dried blood spots using low microflow LC-MS. And as many of you out there probably know, a 6.5% percentage of non-enzymatically glycation of protein amine groups of hemoglobin is known as glycated hemoglobin, or A1C, has been used as an independent criteria for diagnosing diabetes for about 12 years. And A1C is a long-term average of sugar in the blood over 8 to 12 weeks, as we can see in this figure here. And it's highly sensitive to conditions that alter the erythrocyte half-life, such as anemia, chronic renal disease, and also in pregnancy. And so to this end, glycated albumin offers an alternative that reflect a more short-term 2 to 3 weeks blood sugar as compared to instant glucose measurement on the right side here. So K525 of albumin is a lysine that is a glycation hotspot covering 33% of overall glycation. And it has been targeted using MS in a number of studies using different protocols and enzymes. And the most elegant, in my mind, was published by Cato Brede in Stavanger, Norway. So this is just an overview of some different papers out there. But Cato Brede's paper was great because they introduced acetonitrile-assisted fast digestion workflow to monitor the KQ-tau glycated to unglycated peptide. And I know from him that they actually run this assay in clinical routine, and it's used by nephrologists, endocrinologists for diabetic patients with end-stage renal disease. So we think that GA measurements has a great clinical potential, and we first optimized the assay on a 300 samples per day Evosep method with low CVs and with different time and temperature options. We preserve a high precision, low CVs, and we have currently a protocol that is a couple of times faster than previously methods, and this end-to-end protocol takes around 70 minutes. And we have options for dried blood spots and urine coming up, as well as calibration to the internal or to the international standard of glycated albumin. I should also note that DPS sampling may be associated with reduced sample recovery. Our GA assay shows good precision using DPS samples, in part because we measure a glycation ratio. So we see remote microsampling and GA testing as an important alternative to continuous blood monitoring and A1C. So from sugar, I would just and fast protocols, I'll just change gears to a more sensitive and less fast assay, which we have been looking at for some while now. And it is actually not a new clinical case. It was actually first pioneered by Andy Hoofnagel around 2008. And so in patients who have been subjected to thyroidectomy, removal of the thyroid gland due to thyroid cancer, it is known that around 20 to 25% of these patients possess circulating thyroglobulin autoantibodies that potentially impair the detection of thyroglobulin using clinical immunoassays, leading to missed recurrence and additional imaging studies. And this is also shown here by LabCorp, that the accuracy of TG immunoassays drops by increasing thyroglobulin antibody concentration. And so at our hospital, we provide TG and anti-TG tumor marker testing using thermograms, crypto-homogeneous immunoassays. So if patients are which are TG negative, but at the same time possess autoantibodies, they will be subjected to further imaging studies to rule out residual disease through this algorithm here. And thus for patients, the oncologist needs a sensitive and interference-free TG test to optimize follow-up resources and reduce patients' anxiety. So, so our developments combine peptide immune affinity capture using high affinity antibodies and then 100 samples per day method. And we have used this workflow to evaluate more than 50 hybridoma clones, producing monoclonal antibodies against 3 different thyroglobulin peptides. The reason why we have done that is that we need to go very low in sensitivity for the assay. And we have data to support that we have sensitivity below 1 microgram per liter. And our goal is LOQ of less than 0.5. So we think we are getting there, especially for one of the pairs. We have really good results. We will now aim at a clinical validation and assay validation prior to implementation in the clinic. So in summary, targeted proteomics has become an integrated part and valuable tool for biomarker studies in biomedical research. And there's a need for specific, sensitive, standardized assays for biomarker development and ultimately clinical diagnostics. And I should also emphasize that new biomarkers need to improve or change clinical practice and be cost effective. And it's very important that they are not nice to have, but need to have. So we need to find some specific places where our MS-based methods may add value to the patients. So finally, I would like to acknowledge all contributors to this work and collaborators and funding agencies. And I will be happy to take questions in the Q&A session afterwards. Thank you very much.